Welcome back to the deep dive. Today we are venturing into some really specific high-stakes territory in the world of oncology. We're looking at a cancer that is essentially a biological zebra. You know that old medical saying, when you hear hoofbeats, think horses, not zebras?
It's the classic rule.
Yeah.
It means you look for the common diagnosis, not the rare one.
Exactly.
Yeah.
Well, today we are throwing that rule right out the window. We are definitely looking at the zebra. We're breaking down the revised American Thyroid Association guidelines for the management of medullary thyroid carcinoma.
Or MTC, yeah. And honestly, calling this a guideline feels a bit too polite. It reads more like a battle plan for a very, very complex war.
It really does. I was reading through this, and the stakes just felt incredibly high. MTC isn't just a lump in your neck. It's a disease with a genetic destiny. It has some incredibly tricky surgical requirements. And get this, it even comes with legal obligations for the doctor that extend to people they've never even met.
It is a unique beast. And the mission for this deep dive, really, is to unpack those rules of engagement. Because if a doctor treats MTC, like a standard thyroid cancer, the horse, so to speak, they're going to run into serious, and I mean potentially fatal trouble.
So let's start with the biology, because I think that explains why the standard playbook just fails. Most people hear thyroid cancer and they think, oh, that's a good cancer.
Right.
You take a pill, maybe some radioactive iodine, and you're fine. But MTC doesn't play by those rules at all, does it?
Not even a little bit. And to understand why, you have to look at the cells themselves. The thyroid is basically a factory. About 95% of the workers in that factory are what we call follicular cells.
Okay.
They make thyroid hormone, they regulate your metabolism, and crucially, they suck up iodine like a sponge.
And that's why radioactive iodine works on the standard thyroid cancers. The cells just eat it up
And destroy themselves from the inside out.
Precisely. But MTC comes from the other 5% of the factory, the C cells, or parafollicular cells.
Right. And here is the twist. These cells don't actually originate in the thyroid. During embryonic development, they migrate down from what's called the neural crest, which is part of the nervous system, and they just kind of park themselves in the thyroid.
So biologically speaking, they are squatters. They're nervous system cells hiding out in a hormone gland.
That is a perfect way to put it. They are neuroendocrine cells. And that explains why the standard treatments fail. You can't use radioactive iodine because C cells don't touch iodine.
Right.
You can't suppress them with TSH thyroid stimulating hormone because they don't have the right receptors for it. They're operating on a completely different frequency.
So if they aren't making thyroid hormone, what are they even doing in there?
They secrete a protein called calcitonin and another marker called CEA, or a carcinoembryonic antigen.
Yeah.
And this is absolutely critical for you to grasp. Calcitonin is our speedometer.
Meaning what exactly?
In a healthy person, calcitonin should be virtually undetectable. If it's elevated, that tells you there is a tumor present. And the level of elevation correlates directly with how much tumor burden you're dealing with. It tells us how much cancer there is and, well, how fast it's moving.
So it's a perfect warning system. If the number is low, you're safe. If it's high, you're in trouble.
You would hope so. But the guidelines highlight a really dangerous trap here. It's a phenomenon called the hook effect.
The source material made this sound like a nightmare for a lab technician.
Oh, it's a diagnostic disaster. Imagine a patient has a massive tumor burden. I mean, huge amounts of cancer. Their blood is just flooded with calcitonin.
Okay.
When the lab tries to measure it, there's so much calcitonin that it actually overwhelms the antibodies used in the test.
So instead of reading high, the machine gets confused.
Exactly. The assay gets totally saturated, and the machine reads the level as artificially low.
That is terrifying. So you could have a patient who is full of cancer, showing all the physical signs, and the lab report comes back saying, nothing to worry about here.
Precisely. And if the doctor trusts that piece of paper over the patient in front of them, they might miss the diagnosis entirely. If the clinical picture looks bad but the number looks low, you have to know to ask the lab to dilute the sample. Once you dilute it, the interference clears, and the true massive number is revealed.
It's a great reminder that technology isn't infallible, but getting the diagnosis is just step one. The thing that really stood out to me in these guidelines is how much this disease is a family affair. I mean, cancer is usually just bad luck, right? Environmental factors, maybe smoking, but MTC feels predetermined.
That is the genetic destiny aspect of this disease.
Yeah.
We're talking about the RET proto-oncogene on chromosome 10. This one gene is the driver. Now, about 75% of cases are sporadic, meaning they just happen. Bad luck.
Okay, so 3/4 are random.
Yes. Although even in those sporadic cases, the tumor itself often has what we call a somatic mutation, specifically the one called M91AT. If you see that mutation in the tumor tissue, you know you're dealing with a more aggressive cancer. But the hereditary cases, that other 25%, those are the ones that keep endocrinologists up at night.
This brings us to the MN syndromes. Multiple endocrine neoplasia. It sounds like a domino effect of glands just going rogue.
That is a very good description. We have MEN2A and MN2B. MEN2A is the most common hereditary form. You get MTC, but you also have risks for pheochromocytoma, which is an adrenal tumor, and hyperparathyroidism.
And the guidelines mention some weird variants for MEN2A, like itchy skin.
Yes, cutaneous lichen amyloidosis. It's this intensely itchy skin lesion, usually on the upper back. It can actually appear years before the cancer does.
So a dermatologist might actually be the first line of defense here.
Theoretically, yes. If you see that specific rash, you should absolutely be checking the thyroid.
Then there's MEN2B. The source material painted a pretty grim picture of this one.
MEN2B is the most aggressive form, and it has a very distinct look or phenotype. These patients often have a marfanoid habitus, long limbs, very tall, loose joints. They get mucosal neuromas, which are bumps on the lips and tongue.
And there was something about tears.
Yes, infants with MEN2B often can't make tears. They cry, but it's dry. It's a classic sign. But despite all these physical clues, they're often diagnosed late, which is just tragic because MEN2B moves so fast.
Which is why the guidelines completely overhauled how we classify risk.
Right.
They got rid of the old letters.
Exactly. We used to use A, B, C, D. Now, to be more precise, the ATA created new levels based on the specific RET mutation.
Right, let's unpack that. We have HST, H, and MOD. It sounds like military code.
It stands for highest risk, high risk, and moderate risk. HST is the highest category. This includes MEN2B and that M9ATT mutation I mentioned. If a child carries this mutation, the guidelines recommend a prophylactic thyroidectomy.
Just to be clear, we're talking about removing the entire thyroid before the cancer even appears.
Correct. And for the HST group, the recommendation is to do this within the first year of life.
Operating on a baby. Wow. That really puts the stakes into perspective.
It does. But the genetics are so predictive that we know with near certainty that those C cells will turn into an aggressive cancer. We are simply racing the clock.
And the other groups.
For the high-risk group, which includes a mutation at codon 634, they need surgery by age 5. And moderate risk can wait a bit longer, but they still need extremely strict surveillance.
This genetic certainty leads us straight into one of those surprising sections of the guidelines. I honestly thought I'd accidentally opened a law textbook for a minute.
Section E, the ethical quandary.
Yeah, it centers on this tension between patient privacy, and the safety of the patient's family.
It's fascinating because clinical guidelines usually stick to the medicine, but here they dive deep into the duty to warn.
Explain that concept.
Well, the guidelines cite legal precedents, like Tarasoff v. Regents. That case established that privacy ends where the public peril begins.
Usually that applies to a psychiatry patient threatening someone, right?
Exactly. But in the context of MTC, the peril is a 50% chance that a patient's children or siblings have inherited a deadly but preventable cancer gene.
There was a specific case mentioned, Pate v. Frubble. A surgeon was actually found negligent because of this.
Yes. He didn't tell his patient that her condition was genetic and that her children were at risk. The daughter later developed the cancer and sued the original doctor. The court ruled that the physician had a duty to warn the patient of the familial nature of the disease.
But then there was another case that took it even further. Safer via state of PAC.
That one is the real game changer. It suggested that simply telling the patient might not be enough. If the patient refuses to share the information, say they're estranged from their family, the physician might have a legal obligation to breach confidentiality and warn the relatives directly.
That puts the doctor in an impossible position. You're asking them to violate the trust of the patient in the room to save someone they've never met.
It turns the endocrinologist into a guardian, not just of the patient, but of the entire family tree. It's a very heavy burden. But the guidelines suggest that the risk of death from a missed MTC diagnosis outweighs the risk of breached privacy.
It just highlights again how unique this cancer is. You aren't just treating a lump, you're managing a genetic legacy.
Absolutely.
Okay, so let's transition from the courtroom to the operating room. We've diagnosed MTC, maybe through a lump or that high calcitonin level. Now the surgeon needs to go to work. But there's a very specific order of operations here, isn't there?
There is, and violating it can be fatal. It's the pheochromocytoma rule. Remember we said MEN2A patients can have adrenal tumors. Pheochromocytomas to just pump out adrenaline.
Right, the bags of adrenaline sitting on the kidneys.
Exactly. If you take a patient with an undiagnosed pheo to the operating room and start manipulating their neck, the stress of the surgery, the anesthesia, the positioning, it can trigger a massive release from that adrenal tumor.
Like squeezing the bag.
And the result is a hypertensive crisis right there on the table. Blood pressure skyrockets, heart attack, stroke. Patients have died because the surgeon was focused on the thyroid and forgot to check the adrenal.
So rule number 1, check the adrenals. If there's a pheo, it comes out first.
Always. You must rule it out or remove it before you touch the thyroid. Belly first, neck second.
Once the adrenal is cleared, we lift the neck. The guidelines talk a lot about compartments. It's not just about popping the thyroid out like a cherry dip.
No, this is what we call compartment-oriented microdissection. MTC just loves to spread the lymph nodes early. So total thyroidectomy is standard. But you also need to clear the central lymph node compartment. That's the area right around the windpipe.
And this is where our speedometer, calcitonin, comes back into play. The guidelines seem to use the calcitonin number to tell the surgeon how far to dig.
That's exactly right. It's a numbers game. If the preoperative calcitonin is less than 20, the risk of spread to the lymph nodes is low, but you still clear the central neck. If it's over 200, you are almost guaranteed to have spread to the lateral neck, the side compartments.
So the surgeon knows before they even cut that they need to do a much bigger operation.
Right. And if it's over 500, then you are looking at a high risk of spread to the upper mediastinum, the chest, or even distant metastasis.
Oh.
This helps the surgeon decide if they need to do a lateral neck dissection, which is a much bigger surgery with more risks.
There was a specific note about the parathyroid glands. Since we're digging around so aggressively in there, they're at risk, right?
They are. The parathyroids control your body's calcium, and they sit right on top of the thyroid. They're tiny, about the size of a grain of rice. In MTC surgery, because we are cleaning out that central neck so thoroughly, it's very easy to accidentally strip away their blood supply.
So what do? Just leave them and hope they survive?
The guidelines are very specific. If their blood supply is compromised, you take them out. You mince them up into tiny little pieces, and you auto-transplant them. We literally plant them into a muscle.
You plant them where?
Usually into the sternocleidomastoid muscle right there in the neck, or sometimes even the brachioradialis muscle in the forearm.
In the arm. That is wild. You essentially plant them like seeds so they can keep working.
Yes, and it works. They grow a new blood supply and start regulating calcium again. It prevents permanent hypoparathyroidism, which is a miserable condition. And having them in the arm makes them easy to check on later.
That is some next level surgery. So the surgery is done, the patient is in recovery. Now we enter the waiting game. How do we know if we won?
We define a biochemical cure as undetectable calcitonin. If we can't find it in the blood, we assume the cancer is gone. But the source material seems to imply that a lot of patients don't get that undetectable result. What if it's just hovering at, say, 50 or 100? Then the disease is persistent. But, and here's where the real nuance comes in, we don't panic. We look at the doubling time.
Velocity over value.
Precisely. It matters less what the number is and more how fast it's changing. Think of it like a car. I don't care if you are 5 miles down the road. I care if you are going 100 miles per hour or 1 mile per hour.
So if the calcitonin is at 500, but it takes 5 years to get to 600.
Then the doubling time is extraordinarily long. That patient has an excellent prognosis. We call it watchful waiting. We might not even intervene. We just monitor.
But if it doubles in less than 6 months?
That is the red alert. That predicts poor survival and aggressive disease. That's when we start looking for distant metastases in the liver, lungs, bones.
There was one other scenario mentioned, discordance. When the CEA goes up, but the calcitonin goes down. That sounds good initially, right? Hey, calcitonin is dropping. But the guidelines say it's actually very bad.
It is the wolf in sheep's clothing scenario. Calcitonin is a product of a mature, well-differentiated C cell. If the tumor stops making calcitonin but keeps pumping out CEA, which is a more genetic cancer marker, it means the tumor is de-differentiating.
It's forgetting what it is.
Exactly. It's becoming a wild, primitive, rapidly dividing cancer. It indicates the tumors become much, much more aggressive. So dropping calcitonin isn't always a victory if the CEA is climbing.
If we are in that aggressive zone metastasis, rapid doubling time surgery isn't going to fix it. We need systemic therapy. But the source material was pretty dismissive of standard chemo.
Traditional chemodoxorubicin, the stuff that makes your hair fall out, has a dismal response rate in MTC, maybe 15 to 20%. It's toxic and it doesn't work well because MTC cells often divide slowly and chemo targets fast division.
So we need a smarter weapon.
Enter the tyrosine kinase inhibitors, or TKIs. This has been the revolution.
How do they work differently?
Instead of just poisoning everything, they target the specific signaling pathways that the tumor uses to grow. Remember, RET is the driver, so we use drugs that block RET. But they also target VEGF, vascular endothelial growth factor, which is what creates the blood supply for the tumor.
So you starve the tumor and cut the phone lines.
That's the idea. The two big players mentioned are vandetanib and cabozantinib.
And what's the difference between them?
Both are approved for progressive symptomatic MTC. They both show significant improvement in progression-free survival, which just means they stop the tumor from growing for a while. Vandetanib was the first one. It works well, but it has some unique side effects, specifically something called QTC prolongation, which is a heart rhythm issue and a bad rash.
And cabozantinib.
Cabozantinib came later. It targets RET and MET and VEGFR. It's potent. The side effects can be rough. Patients get hand-foot syndrome, where the hands and feet get red, painful, and start to peel. And notably, it has a risk for GI fistulas.
Holes in the intestines.
Yes, it's serious.
And the crucial caveat here is that these aren't cures, right?
That is the hard truth. They are not curative. They control the disease. And eventually, the tumor usually figures out a way around the blockade. Resistance develops.
So it's a game of chicken. You don't want to start the treatment too early.
Exactly. That's why we don't start these drugs just because the calcitonin number is rising. We wait until the disease is clinically progressive, meaning we can see it growing on scans according to strict criteria. Because once you start, you are on a clock. You want to save that ammunition for when you really need it.
It really is a balance of quality of life versus tumor control.
Absolutely. The guidelines emphasize that we treat the patient, not the number. If a patient has a high calcitonin but feels fine, and the tumor is growing slowly, we wait. If they have diarrhea, pain, or rapid growth, then we treat.
I want to circle back to something you mentioned earlier about the zebra nature of this disease. We've covered genetics, surgery, legal issues, targeted drugs. It feels like MTC requires a completely different mindset than other cancers.
It really does. With papillary thyroid cancer, the horse, we are often de-escalating care because it's so slow growing. With MTC, we have to be aggressive early, especially in those high-risk genetic kids. But then we often have to pump the brakes in adults with metastatic disease because the treatments have such high toxicity. It requires a lot of judgment.
So if you had to summarize the take-home message from these massive guidelines for our listener, what would it be?
I would say it's the shift from a one-size-fits-all approach to true precision medicine. We don't just cut it out anymore. We screen the DNA of infants, we measure the velocity of blood markers, we use drugs that target specific molecules. It's just a much more nuanced, sophisticated way of practicing medicine.
And it raises that provocative question we touched on in the ethics section.
Right. In the age of genetic medicine, who's the patient? The ATA guidelines make it clear that the physician's responsibility extends beyond the person sitting in that exam room. It extends to the unborn child, the estranged sibling, the entire genetic line.
It forces us to ask, do we treat a patient or do we treat a family tree?
Exactly. MTC might be a rare zebra, but it teaches us lessons about genetics, ethics, and precision that apply to the future of all medicine.
Well, there you have it. The rules of engagement for medullary thyroid carcinoma. A complex, fascinating, and really high-stakes battleground. Thanks for guiding us through it.
My pleasure.
And to you, the learner, thanks for diving deep with us. We'll see you on the next one.